Myself, Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important session. In today's topic of discussion, we are going to start off with the lesions which are arising from the intestines, okay, that is from mainly the colon, okay. So today we are going to start off with a series of lectures, okay, that is the colorectal polyps and adenomas. Now, this colorectal polyps and adenomas, it will be covered under 3 lectures. So in the first lecture, we are mainly going to discuss in details about the serrated lesions and the polyp. In the next lecture, we are going to discuss in details about the conventional colorectal adenomas. And in the third lecture, we will cover some of the other important, polyps, as well as we will discuss the familial polyposis syndrome in details. So without wasting any time, let us begin today's topic of discussion. Today, we are going to start off with the first part of colorectal polyps and adenomas. So before we go into the details of today's lecture, first we will see that what is the basic classification of the different kinds of polyps which are arising in the colorectum. So basically we are having benign epithelial tumors and precursors mainly. So we are having basically in the first group, we are having the colorectal serrated lesions and polyps, which is the basic point of discussion of today's lecture. So this will be covered in the first lecture only. That is, in today's session, we will cover in details about the colorectal serrated lesions and polyp, and remember, this serrated lesion itself is asked as a long answer question in the exam. Okay, so what are the entities under the heading of colorectal serrated lesions? So we are having hyperplastic polyps, which can be microvesicular or goblet cell type. Now the microvesicular type is the more common variety and the goblet cell type is the lesser common variety. Okay, then the next important serrated lesion is SSL, that is standing for sessile serrated lesion. Okay, then we are having sessile serrated lesion with dysplasia, okay, abbreviated as SSLD, and finally we are having TSA, that is traditional serrated adenoma. Okay, so these are the list of colorectal serrated lesions and polyp. Okay, and today we are going to discuss them in details. Now the next group of group of polypoid lesions include conventional colorectal adenoma. So what are the entities discussed over here? We are having tubular adenoma, villus adenoma, tubulovillus adenoma, which can be high grade or low grade. Okay, and then we are having advanced adenoma. So these are the entities which is covered under the section of conventional colorectal adenoma. Okay, and this will be covered in the second lecture or in the second series of colorectal polyps and lesions, okay, and adenomas. And lastly, we are having some other lesions also, like inflammatory polyps, okay, hematomatous polyps. So under the heading of hematomatous polyps, we are having juvenile polyposis syndrome as well as Peutz-Jeghers syndrome, okay. So we will discuss them in details as well. And lastly, we are having familial polyposis syndrome, which can be asked as a long answer question in the exam as well. Okay, and also the conventional colorectal adenoma is also an important long answer question in the exam. So there are 3 very important, LAQs which are asked from here. So they are covered in the separate lectures. Okay. Now, before I move any further, try to understand that in Robbins' 10th edition, okay, a very old concept of polyp classification is given, which I have also taught in the previous lectures. But now, given the current scenario and the current molecular scenario and the molecular alterations which is seen, we cannot classify them like this. So earlier, in Robbins, if you see, the polyps has been divided as neoplastic, that is the adenomas, and non-neoplastic polyps. So under the neoplastic headings, you were having the conventional adenomas, that is tubular adenoma, villus adenoma, tubulovillus adenoma, and you used to have sessile serrated lesions or sessile serrated adenomas, okay. Whereas under the non-neoplastic heading, we used to have hyperplastic polyp, inflammatory polyp, and hematomatous polyp. But this kind of classification, okay, it is not very correct type of classification, because for example, I will tell you, hyperplastic polyp cannot be called as non-neoplastic. Okay, because although they are, they have a very less chance of, turning into a malignancy or into a malignant polyp. Although the chances of turning into a malignant polyp is negligible, but yet it is having certain mutations or molecular alterations, because of which we cannot call it as non-neoplastic. Okay, so it shows some clonality as well, and in very rare cases it might act as a precursor and give rise to lesions like SSLs. Okay, so we cannot consider a hyperplastic polyp, though it has very reduced risk, we cannot consider it as non-neoplastic. Secondly, we can see hematomatous polyp, which is having the juvenile polyposis and Peutz-Jeghers syndrome. So basically these polyps, okay, although the sporadic lesions, okay, they do not pose much of a malignant threat or the threat of transformation, but the syndromic presentations like JPS and Peutz-Jeghers syndrome, the syndromic presentations and even the familial presentations, okay, they are carrying a very high risk of transformation to colorectal adenocarcinoma in the future life. So that is why it is not correct to place these entities like hematomatous polyp and hyperplastic polyp, okay, as a non-neoplastic entity. So that is why the correct definition is as here, okay. So these are all benign epithelial tumors and they are precursors. Okay, so there are three headings. One is the colorectal serrated lesions and polyps, conventional colorectal adenomas, and then there are others which is comprising of inflammatory polyp, hematomatous polyp and familial polyposis syndrome. Okay, so I hope this classification is crystal clear to everyone and why we have shifted from the earlier classification based on Robbins as neoplastic and non-neoplastic, and we have moved to this particular classification. Okay, so let us begin. So if you see what are polyps, remember polyps basically they are most commonly present in the colorectum, okay, but it doesn't mean that it is not seen in other parts of the GI tract. It can also occur in the esophagus, in the stomach as well as in the small bowel, okay. The incidence in the esophagus and small bowel is very less, okay, as compared to the stomach. So if you see in the stomach, we have already discussed the different kinds of polyps which are arising, okay, from the stomach. Now polyps, if you see, they can be either sessile, that is without a stalk, or they can be pedunculated, that is having a stalk. So this is basically sessile polyp, where you can see that there is no pedicule or there is no stalk, okay, it is just acting as an elevation. Whereas a pedunculated polyp, if you see, they are basically having this particular stalk, okay. So there is a pedicule or there is a stalk over here, okay. So this is the meaning of a sessile polyp and a pedunculated polyp. Now coming to the topic of discussion, that is for today's topic of discussion or today's lecture, we will discuss about the colorectal serrated lesions and polyps. And what are the entities that we are going to discuss? We are mainly going to discuss about the hyperplastic polyps, both microvesicular and goblet cell variety, sessile serrated lesion, that is SSL, as well as SSL with dysplasia, as well as we will discuss about the traditional serrated adenoma. So please pay a lot of attention. I am going to discuss very important practical points which is going to help you to differentiate between these important lesions, and mind it, this can come as a very important exam slide, okay. So these can come as an exam slide and then the viva will go into the differentiation of each, and it is asked as a long answer question in the exam. So the colorectal serrated lesions and polyp, if you see, they are these group of lesions, if you see, they are characterized by sawtooth or serrated or stellate architecture of the epithelium. So what is that? I will show you, okay. Now if you look at the frequency, so if you see, the colorectal polyps as a whole, if you see, then the hyperplastic polyps, they are constituting 30% of all the colorectal polyps, okay. Whereas the sessile serrated lesion, they are constituting 10% of all the colorectal polyps, and the traditional serrated adenoma, they are constituting only 1% of all the colorectal polyp, okay. All the colorectal polyps means what? Including everything, including the colorectal serrated lesions and polyps, including the adenomas and including all the others. So among all the colorectal polyps, okay, hyperplastic polyps are constituting 30% of all the colorectal polyps. They are very common, and most of the hyperplastic polyps, they are arising in the distal colon and rectum, that is on the left side, okay, they are arising on the left side. And if you see, among the serrated colorectal polyps, they are the most common variety of serrated colorectal polyps, constituting 80% of all the serrated colorectal polyps. So among the colorectal serrated polyps, if you see, hyperplastic polyps are the most common, comprising 80% of all the serrated polyps. Whereas among all the colorectal polyps, if you see, they are constituting only 30%. They are basically seen in adulthood, okay, and they have little or no associated risk of colorectal cancer development. So the risk of development of cancer, colorectal carcinoma, is very less or negligible, okay. But remember, we cannot say it as a non-neoplastic because there are certain mutations which are present over there, certain molecular alterations are present over there. So you cannot call it completely as non-neoplastic, okay, and it occurs in males more than females. So this is about the basic epidemiology of the hyperplastic polyps. Now coming to the sessile serrated lesions, as I told you, they are comprising 10% of all the colorectal polyps. Okay. Now remember, most of these sessile serrated lesions, they arise from the proximal colon, okay, especially the SSLDs, that is the SSLs with dysplasia, that is on the right side, okay. So most of these sessile serrated lesions are arising from the proximal colon, especially the SSLDs, that is from the right side, and they account for only 10 to 25% of all the serrated colorectal polyps. Okay, so they are constituting only 10 to 25% of all the serrated polyps or the serrated lesions. Okay, the incidence increases with age. Okay, and these are considered neoplastic with a pre-malignant potential. So they are acting as a precursor lesion. Okay, acting as a precursor lesion, and they are more common in women and smokers. And coming to traditional serrated adenoma, they are constituting only 1% of all the colorectal polyps, and approximately 70% of the TSAs, they are arising from the distal colon and rectum, just like the hyperplastic polyp, that is on the left side. And again, these are also neoplastic polyps showing dysplasia. And the patients are usually more than 50 years of age, and there is no gender predilection for traditional serrated adenoma. So I hope the epidemiology of each one of these lesions is crystal clear to everyone. Now remember, in the current WHO 5th edition, remember one very important change is there, that the term SSP-SSA, that is sessile serrated polyp or sessile serrated adenoma, this term was used interchangeably, and it used to create a lot of confusion. So in the current WHO 5th edition, the term SSP or SSA/SSA, it is not recommended for use. We are only having sessile serrated lesion, okay, or we are having sessile serrated lesion with dysplasia, and the other lesion that we are having is traditional serrated adenoma. Okay, so sessile serrated lesion is different from a traditional serrated adenoma. They are not and they are not or. Okay, so this term is no longer used. Sessile serrated polyps or sessile serrated adenoma, this particular terminology is not used anymore. Rather, you will use sessile serrated lesion, and if dysplasia is present, you will just add with dysplasia. And the other thing that is there, the adenoma, that is traditional serrated adenoma, that is a separate entity altogether. Now, presence of dysplasia is to be reported, but grading is not recommended. Okay, so you should just you should just mention about the presence of dysplasia, but you should not grade the dysplasia. Okay, this is especially in case of the colorectal serrated lesions and polyp. I am not talking about the other conventional adenomas. I am only speaking for colorectal serrated lesions and polyp. Now, if you look at the etiology of such lesions, it is very similar to colorectal adenocarcinoma. That is, what are the risk factors? Consumption of processed and red meat as well as alcohol, obesity, okay, smoking, increased dietary fiber intake or increased physical activity, as well as the consumption of NSAIDs, okay, as well as HRT, that is hormone replacement therapy in women. All these last three factors that we have seen, they reduce the risk of development of such polyps. Okay, so consumption of processed and red meat and alcohol, obesity and smoking are increasing the risk, whereas increased intake of dietary fiber, increased physical activity, use of NSAIDs and HRT therapy in women, they decrease the risk of such polyps. Now coming to the pathogenesis, which is again very important, because a lot of molecular details is there in under the pathogenesis. Okay, and this is very important. The molecular pathogenesis of serrated lesions is a very hot topic which is asked in the exam. So approximately 30% of the colorectal carcinomas, they arise via serrated neoplasia pathway. So just to give you an idea, there are two pathways via which the colorectal carcinomas arise. One is the traditional conventional pathway is there, okay, APC beta catenin pathway is there, and another pathway is there is the serrated neoplasia pathway. Now what is happening, that usually the conventional adenomas, they are going via one pathway, whereas the serrated lesions, they are going via another pathway. Okay, so that is why around 30% of the colorectal carcinomas are arising via the serrated neoplasia pathway. Okay, and what we are discussing today are the precursor lesions. Okay, the precursor lesion. What precursor lesion? Especially the SSLs and TSA. These are known precursor lesions, okay, of the colorectal carcinoma arising via the serrated neoplasia pathway. So these precursors, okay, via this pathway only, they are going to give rise to colorectal carcinoma. SSA and TSA are the known precursors of carcinoma, as I have already discussed. Hyperplastic polyp, mainly the microvesicular variety, is a probable precursor to SSL. So it is a precursor, it is a probable, okay. Rarely it might give rise to a SSL, okay, but it is not a very, usually it has a very, reduced or negligible potential to give rise to any carcinoma. So that is why earlier they used to use the term non-neoplastic for these lesions, but you cannot name it as non-neoplastic because they are harboring certain mutations, which I will show you, okay. Now the other group, that is the goblet cell variety of hyperplastic polyp, and some of the microvesicular variety of hyperplastic polyp may also give rise to traditional serrated adenoma. That is why hyperplastic polyps cannot be called as completely non-neoplastic, okay. Rarely they might give rise to both SSLs and TSA, which is a very, is a known precursor for carcinomas. Now, lesions may arise via two pathways of the serrated pathway. Now, serrated pathway also has two pathways. One is the BRAF variety of serrated pathway and another is the KROS variety of serrated pathway. Now, the serrated lesions, if you see, they arise from either of these pathways, but the traditional serrated adenoma can arise from either the BRAF serrated pathway or via the KROS serrated pathway. Whereas the microvesicular hyperplastic polyp as well as the sessile serrated lesions, SSLs, they are arising from the BRAF serrated pathway only. Whereas the goblet cell variety of hyperplastic polyp, they are arising from the KROS serrated pathway. Okay. WNT pathway activation occurs in all pathways through different mechanisms. Okay. At which stage? At the stage where there is transition to dysplasia, and I will show you. So please look at this particular chart very carefully, and one by one I am going to explain you in details, okay, that how the malignant transformation occurs, okay, via the serrated pathway. So the first pathway is this pathway. So the normal mucosa via the BRAF mutation, okay, they give rise to the microvesicular hyperplastic polyp, which can develop a CpG island methylator phenotype, high type, okay, and give rise to SSL, that is sessile serrated lesion. Not only this, the normal mucosa can also directly convert into a SSL as well. Okay. Now once they develop into an SSL, this SSL can go via two pathways. The first pathway is via MLH1 promoter region methylation. In this case, what will happen, that there will be MLH1 deficiency, and it is going to give rise to a dysplasia, that is SSLD, that is sessile serrated lesion with dysplasia. But because of the MLH1 methylation, it is MLH1 deficient. So we call it as MLH1 deficient SSLD. Okay, and remember, at this stage where the lesion is converting into a dysplasia, there is WNT activation. And what is the mechanism? Via MLH1 promoter region methylation. Okay, giving rise to what is called as MLH1 deficient SSLD, which over a period of time can acquire more and more mutations to give rise to BRAF mutated MMR deficient carcinoma. Okay, this is one of the fate of the SSL. Another fate of SSL is that again the WNT pathway activation can occur, but via another pathway. Like over here there was MLH1 promoter region methylation. Over here there can be TP53 mutation also leading to WNT activation, leading to MLH1 proficient. So over here there is nothing wrong with the MLH1. It is not methylated, it is not silenced. It is very much working. So we call it as a MLH1 proficient SSLD. And this over a period of time will give rise to BRAF mutated but MMR proficient carcinoma. Okay, MMR proficient carcinoma. Now this is the one pathway, that is basically the normal mucosa via the BRAF mutation, they can form SSL and then they can go via this pathway. By another pathway, but remember over here the phenotype is the basically the CpG island methylator phenotype, high type. Okay. Whereas the normal mucosa can also give rise to a BRAF mutated traditional serrated adenoma or TSA. Okay, which basically over here also there is a CpG island methylator phenotype, but it is not the high type. It is just a CpG island methylator phenotype. Now this BRAF mutated traditional serrated adenoma can undergo TP53 mutation and lead to what is known as activation of the WNT pathway, leading to a BRAF mutated TSA with high grade dysplasia. Okay, with high grade dysplasia. So remember, whenever there is a WNT pathway activation via any mechanism, it is giving rise to dysplasia. Over here, the SSL was converting into SSLD, and over here, the TSA is converting into TSA with high-grade dysplasia, which ultimately over a period of time can give rise to again a BRAF mutated MMR proficient carcinoma. Okay. So this is basically the BRAF serrated pathway, and over here we can see that how a microvesicular hyperplastic polyp can arise, how an SSL can arise, how an SSLD can arise, and also a TSA can arise via the BRAF mutation. Okay, so this is the basic pathogenesis of the BRAF serrated pathway. Now the another group of mutations can occur, that is the KROS mutation, which can give rise to a goblet cell hyperplastic polyp, which can have a CpG-RA methylator phenotype, low type, okay, low risk variety, which gives rise to KROS mutated TSA or traditional serrated adenoma, which can undergo TP53 mutation leading to WNT activation. And whenever WNT activation will be there, what will happen? So whatever lesion was there, they will have high grade dysplasia in addition, and which over a period of time will give rise to a KROS mutated MMR proficient colorectal carcinoma. This is the KROS serrated pathway. So this is the basic pathogenesis or pathophysiology of origin of serrated lesions. Okay, very important. Okay, now one more thing I would like to discuss before I go into the macroscopic and microscopic examination of these polyp. So remember, the pathogenesis of hyperplastic polyp, if you see, it is not completely understood, but it has been hypothesized to occur due to decreased epithelial cell turnover and delayed shedding of the surface epithelial cells, which leads to piling up of the cells leading to polyp formation, that is hyperplastic polyp formation. This explanation has been given in Robbins. Okay, so that is why I have given. Maybe some examiner can ask you this. Okay, now you also have to remember that 75% of the SSLD, that is sessile serrated lesion with dysplasia, they show MLH1 promoter methylation leading to MMR deficiency, as we can see over here, this part. So basically around 75%, this pathway basically occurs in 75% cases. The SSL will have this MLH1 deficiency and they will give rise to SSLD, MLH1 deficient SSLD. Okay, whereas 25% of SSLD, they can show TP53 mutation and they are MMR proficient, as I can show you over here. 25% they can have TP53 mutation and they can give rise to MLH1 proficient SSLD. Okay. Next, we will see the macroscopic appearance of individual lesions. So first we will see the macroscopic appearance of your distal hyperplastic polyp. Now these are basically small, less than 5 mm in size, and they present as discrete mucosal elevation like this. Okay, this is about your distal hyperplastic polyps, whereas the proximal hyperplastic polyps and sessile serrated lesions, mainly the sessile serrated lesions, they are quite pale and they are poorly defined. You can see that they are very poorly defined lesion. As you can see, they are defined. They can be sessile to flat lesions. Sessile means if this is basically the floor, it is arising, just an elevation is there. This is sessile. Or it can also present as a completely flat lesion. Completely a flat lesion can be there as well. Okay, and these lesions are covered with a mucus cap and a rim of debris. You can see at this particular area there is a rim of debris which is formed, and this is the surface mucus cap. This is the surface mucus cap. Okay, and overall this gives a cloud-like surface. It forms a cloud-like surface. Okay, this is about the SSLs. These are all the endoscopic appearance view. And if you look at the TSAs, that is traditional serrated adenomas, these are polypoid and they are broad-based lesions with surface resembling coral pattern. As you can see, they are resembling like a coral. Whereas this is about your TSAs, whereas the proximal TSAs, this is mainly about the distal TSAs. And distal TSAs, they are more common, just like your distal HPs, which are more common in comparison to the proximal lesions. The proximal TSA, they present as a flat lesion. Okay, so this is basically about your macroscopic appearance of the serrated lesions. Now we will first see, once by once, we will see the microscopic examination. So first we are going to learn in details about the hyperplastic polyp. So first I will read out what are the individual points, and then I am going to show you with the help of diagram and explain you, okay, in details, okay, how to recognize and differentiate each polyp from the other lesion. So hyperplastic polyps, remember, in case of hyperplastic polyp, I hope you remember what is a villi and what is a crypt. Okay, villi is up and crypt is down. This is a villi, this is a crypt. Okay, if you see villi, crypt, so anything which is going and down is the crypt. Okay, so over here if you see the hyperplastic polyps, if you see over here, these serrated crypts are straight, narrow and evenly spaced. So whatever crypts that you see, they are straight, narrow and they are evenly spaced. So architecturally they look very normal like. Okay, so they are very properly arranged. So architecturally they are very uniform. The word is uniform. They are straight, narrow and evenly spaced. If you look at the lining epithelium, they are lined by serrated epithelium with serrations limited to the upper two-thirds. I will show you what serrations are. Normally, if you look at a gland, if you take the transverse section of a gland, the lumen is basically round. But in case of serrated polyps, the lumen is basically star-shaped. Okay, this is called as serrated appearance. Okay, so in serrated polyps, you will see this. Now, what do you mean? Over here, if you see, if this is the particular hyperplastic polyp, okay, the serrations, if you see, they are limited to the upper two-thirds only. The lower one-third part does not show any serration. The upper two-thirds part is going to show the serration. The proliferation zone of hyperplastic polyp is confined to the crypt bases. And remember, there is no basal dilatation. So if you see, if this is the crypt, if you see the crypt base, this is the crypt base. This is narrow, this is not broad. So there is no basal dilatation. There is no architectural distortion. All the crypts, if you see in case of hyperplastic polyps, they are arranged, they are longer, they are arranged uniformly across each other. Okay, and there is no complex architecture over here. And there is no submucosal encroachment or, growth, not growth, submucosal, displacement of epithelium is not there. So why I am saying that these things are not there? Because these things are present in SSLs, and that is going to help us to differentiate the hyperplastic polyps from SSL. So remember, in case of hyperplastic polyp, there is no basal dilatation, there is no architectural distortion, and there is no submucosal encroachment in the hyperplastic polyps, whereas all these features are present in case of SSLs. And remember that there is no dysplasia in hyperplastic polyp. Now, before we come over here in the section of the, how to differentiate the microvesicular and the goblet cell variety, I will first show you the basic feature of the hyperplastic polyp. So, as you appreciate over here, this is the hyperplastic polyp, mainly the microvesicular hyperplastic polyp. So, the first important thing that you see, if you look at these crypts, what are these? These are the different crypts. So, the crypts are uniform. So they are architecturally, they are uniform. Okay, so they are long in comparison to the normal, glands. They are longer in size, yes. And very importantly, if you see that they are narrow, they are long, they are narrow. Okay, and very importantly, you can see that there are serrations. So these are the serrations. Can you see the serrations? But if you see the serrations, they are limited to the upper two-thirds part only. The serrations are there. These serrations over here, if you see, they are there in the upper two-thirds part only. They are not reaching the base. And if you see at the base, if you see, they are narrow. The crypts are narrow. So there is a narrow crypt. There is no basal dilatation of crypts. So there is narrow crypts. Okay. There is no basal dilatation over here. And very importantly, if you look at the cytological features, the cells are completely bland looking. If you see, the cells are bland, the nucleus is round, uniform, and they are basally located nucleuses. You can see they are basally located. Okay, so there is no dysplasia whatsoever, no dysplasia is there. Okay, and you can see occasionally, you can see the presence of goblet cells over here. So this is the microvesicular variety. Now, why am I calling the microvesicular variety as microvesicular? Because the majority of the cells, these lining cells, if you see, they are having a certain characteristic. So they are having the presence of apical vesicles. Okay, that is why it gives a microvesicular appearance. Okay, so that is why this is called as a microvesicular hyperplastic polyp, because majority of the lining cells, okay, they are having abundant cytoplasm and apical vesicles are there. Okay, so and majority of these cells, okay, they are this microvesicular type with only very few goblet cells. Okay, so in the microvesicular variety of hyperplastic polyp, if you see, you will see majority of these cells are in this particular, they are microvesicular type, whereas in the goblet cell variety, if you see, the majority of these cells are the goblet cells. Okay, I have not shown goblet cells over here, goblet cell variety over here. Okay, now let me show you with the help of diagram. So if you see over here, this is a hyperplastic polyp. Now first important thing that you can you see that basically there are these different crypts, as I can tell you. So over here, these crypts, if you can see, they are in the transverse section, whereas this crypt over here, this is in the longitudinal section. So what I want to tell you is that all these crypts, okay, they are uniformly arranged. They are not having a complex arrangement. They are one by one, they are arranged like this. They are narrow, uniformly arranged, and they are narrow. If you look at the crypt, okay, if you look at the crypt, basically, I will show you in the next diagram. Let me show you. If you look at the crypts closely, so the serrations, if you see, they are mainly present. These serrations, if you see, they are mainly present in the upper 2/3 part, not in the lower part. Okay, this is very important thing to understand. So serrations, they are ending in the upper 2/3 part. The basal part, if you see, they are narrow. They are not dilated. They are narrow. Okay, and if you look at the lining cells, okay, if you look at the lining cells over here, they have basally located bland variety of nucleus. And this variety that we are seeing, this is the microvesicular variety, because the individual epithelial cells, if you see closely, they are having basally located nucleus, abundant cytoplasm, and microvesicles, apical vesicles are there. And you can see this is the transverse section. You can see the serrated, transverse section. Okay, they're star-like sterate, okay, stellate in appearance. So this is mainly your hyperplastic polyp. This is your hyperplastic polyp. Okay. So let me just compare and contrast between the microvesicular variety of hyperplastic polyp and goblet cell variety. Now these features that I have discussed, they are common to both of them. These are the main features of a hyperplastic polyp. Now I am discussing some specific features. Now remember, the microvesicular variety of hyperplastic